All right, so good with intro. Morning, everybody. Joining us, welcome back to GIM Grand Rounds. We have Dr. Pat Fehling with us again. For those of you who weren't able to join last week, he's an addiction psychiatrist here at the university and spends half his time in private practice, and then his other half is over at Cedar. He spoke with us last week about how to think about alcohol use disorder, thinking about diagnosis and management of that common condition. And then he's back this week speaking with us about optimal approaches to stimulant prescribing. This, of course, for seeing patients has become quite a common thing for us. I think over the past 5 to 10 years, it's become remarkably prevalent in our practices. And so I asked him to speak with us about how to think about this so that we're doing a good job by our patients. So Dr. Fehling, thanks for joining us. Looking forward to your talk.
Well, Brandon, thank you. So once again, thanks for having me back this week. Last week, we kind of walked through kind of spectrum approaches for looking at alcohol. Today, we're going to talk a little bit about stimulant prescribing. I think a lot of talks, people will start and say, oh, this is a topic near and dear to my heart. This is probably more of a topic that's a thorn in my side. And I'll expand on that a little bit, but these are some of the, ways of thinking that I've used over the years to look at this. As always, I'll kind of pause at a couple points and we'll kind of field questions from the chat and a few different things. As Dr. Coombs said, I'm half-time at Cedar, and I can talk a little bit about Cedar in terms of the model of care that we've been providing. We actually, very pertinent to this talk, we have a very intense run of folks these days struggling with amphetamine. So meth is ubiquitous, really, of everybody we're seeing. It's actually very rare that I'll have somebody struggling with just fentanyl and not meth. It's almost always some element of meth that seems to be just added on to people's struggles, which I think is very fascinating. But today, it's more going to be the topic of prescription amphetamine. So specifically looking at Adderall, Ritalin, and just some of the data around this. These are some of the objectives that I kind of laid out. Spectrum of disease presentation ranging from what I would say true ADHD to stimulant use disorder, collaborative approaches and clinical boundaries pertinent to stimulant prescribing, and then we can talk a little bit about maybe some scenarios that we've seen in practice. So these are the core symptoms of a stimulant use disorder. And ADHD, or sorry, not a stimulant use disorder, of ADHD. ADHD is kind of broken into two halves. There's an inattentive subtype and then a hyperactive subtype. And then there's a lot of young people really fall under a combined subtype. 6 or more symptoms for children up to age 16, 5 or more for 17 and older, symptoms present for at least 6 months. As you see, a lot of things in the realm of distractibility. So a lot of times you'll have a patient in your office who will say, I can't concentrate, or I can't focus, I can't meet the needs of my life. These are some of the hyperactive symptoms that we're looking at. Fidgety, leaves their seat. Oftentimes the hyperactive symptoms are going to be much more prevalent in youths. And it's very often that really boys in school will get much more aggressively diagnosed with ADHD than girls. That's really based on the visibility of it. So in terms of if boys score higher on hyperactive symptoms, they're going to get flagged more often by a teacher, that it's more of a behavioral issue instead of just they're just falling behind, where they're kind of daydreaming, I guess. It's very important that ADHD does require several symptoms were present before age 12. We look at this a lot in our evaluations of folks, including at Cedar. The idea of adult onset ADHD is not a real condition. That's something else, or that could have been ADHD all along. But this is really more of a baseline struggle that folks have really with their brain, and it's really about the prefrontal cortex. I think it's very important to understand what are the conditions, especially with the adults that we're seeing with distractibility and with kids, and what are the other on the differential, I guess. So one of the biggest ones is actually PTSD. So we see this all the time. Actually, in very sophisticated child psychiatry approaches, they will start, and this is actually, even in a research, there's actually a child SCID, which is a structured clinical interview. They'll actually start with the topic of trauma, and they'll say, and that'll be either A or B. Are people and have a sizable traumatic background or not? And if they do, it moves the diagnosis totally on a different cascade, and very often away from things like ADHD, and you're using more of like a trauma framework. We actually look at this at CEDAR as well. We have a lot of folks, a chief complaint is that they can't concentrate or that they're distracted. They'll very often say, I have a prior diagnosis of ADHD. And then it's difficult for us to determine how we're supposed to approach this, but I'll actually talk about some of the preliminary data that we actually found. Mood disorders can present as distractibility, personality disorder, substance use disorder, eating disorders, OCD, and psychosis. So there's quite a bit of things on the differential. We have a lot of folks who want to skip a lot of that and jump right to an Adderall prescription. All right, so stimulant use disorder. I actually touched on this a little bit last week. These are the 11 symptoms of any addictive disorder. We use the alcohol framework of walking through these 11 symptoms are what really matter, but the same overall symptoms apply. And once again, use disorders used to be two conditions. So it used to be the idea of substance abuse versus substance dependence. And for substance use disorder, we combine these together. And then once again, a mild use disorder is 2 to 3 symptoms, moderate is 4 to 5, and then a severe is 6+. Extending once again to what I was talking about last week, of the folks we have, let's say with alcohol use disorder or opioid use disorder that we see at CEDAR in residential care, they're 11 out of 11 in terms of the real symptoms. Every one of the folks that we're working with has a very severe use disorder. But it gets really complicated when we're kind of straddling this kind of more mild. So I think the idea of patients being prescribed a stimulant in an office-based practice, what do you do if they have maybe one symptom or maybe two, and they're in this kind of territory, maybe a use disorder mild? How do you then handle that? All right, so this is our prescriber dilemma. So how do we validate a true presentation of ADHD, how to differentiate distractibility caused by ADHD from another potential source of impairment, and then how to emphasize safety and limit adverse outcomes frequently experienced from stimulant prescribing. Okay. I'll cut to the chase. I don't have wonderful answers for number one. Right? I can say, oh, you can have them go to testing. Well, if your folks have $5,000 that they could pay a psychologist for thorough 20-hour testing, sure. But other than that, we have to use more of our clinical judgment in how to analyze this. So I'll skip right, at least for this talk, to number 3, and then we'll kind of back it up. It's better to understand, at least from our purposes, with some of the outcomes and how to navigate them. So what are these kind of the negative outcomes? So the most severe is going to be overdose or an iatrogenic addiction from stimulants connected to prescribing. So stimulant overdose, tachycardia, arrest, infarction, agitation, hypertensive crisis, mood instability, insomnia. Okay, so if somebody is struggling, if you're prescribing them an Adderall and they're getting healthcare, they're going to the ER for some of these kinds of things. This was an interesting paper that I found. This was 23,000 poisoning exposures. This was out of Philadelphia. And really the take home was which of the prescribed stimulants seemed to have the most risk attached to them. And number 1 was actually immediate release Adderall, or dextroamphetamine. The second place was the extended release, and then last was Vyvanse on this list. It's also interesting to know that of what was the explanation of the poisoning exposure. So children's most often exploratory exposure with incidental ingestion of pills that work for them. Age 6 to 12 is the therapeutic error. So they maybe accidentally took dosing wrong, or they had already taken their dose, took an additional dose, something like that. And then adults, it starts to get more nuanced. Suicide attempt was in the range of about 28%. Quote abuse was about 20% of the folks with poisoning issues. In very practical terms, if I have a patient, and most of the patients I'm working with are in recovery from a substance use disorder, I'm very rarely looking at immediate release Adderall. It's like we're trying to pump the brakes, if you will, about any sort of stimulant prescribing at all. And of the times where we are considering stimulant prescribing, then we're really shying away from some of the immediate release products. Okay, what are the risk factors for somebody developing a new addiction connected to these prescriptions? So the number one risk factor is really a previous substance use disorder. So that's important to understand. I think if you have a number, there's a lot of complexities involving topics of trauma, mental health, co-occurring issues, social determinants of health. But the number one risk factor for a substance use disorder is another substance use disorder. Okay, so that should definitely be part of your screening and working with some of the patients. But clinically significant trauma seems to play a very significant role, especially earlier in life. And I'll talk a little bit about this. And then also, I think the idea of context, what people's life looks like. So we pay a lot of attention at CEDAR of who they're living with or what their overall lifestyle looks like. So it's very rare. Like for instance, if I have an individual who is struggling with amphetamine use, fentanyl use, and they have a significant partner, very high likelihood that the significant partner is using the exact same substances as what they're using. Okay, some of the, I kind of frame this as more of what I call the moderate negative outcomes. Diversion of pills. Malingering is an interesting topic with this, and there's, like most things, there's a spectrum of malingering. So how many people on the CU Boulder campus are getting sporadic doses of Adderall to catch up or cram for exams, performance enhancement kinds of things. And then I actually also put this, I think a moderate negative outcome is failure to reach disease remission. And that includes the misdiagnosis of, let's say, something like PTSD. And what I mean by that is very often folks will have an issue with distractibility. They'll say, I have a childhood diagnosis of ADHD. If you could please restart me on Adderall. We do. And if you really track their functioning, it's not going up. I'm just not convinced that they are really getting better over their life. And so a lot of providers will just keep hammering the stimulant prescribing, dosing and changing around dosing, and it's all just about that, and a little bit at the patient's request, but they might be neglecting a very important core condition that might be actually running the show. And that could be something like PTSD or a primary mood disorder. Some topics around prescription diversion. These are some of my own terms, just so you know. So I call this partial diversion, or go ahead.
Well, just on your last one, I mean, students who take it for performance enhancement, is there any data that shows that they actually do better or do worse on the drug? Or?
They seem to do better. At least, I mean, this is, I don't know about the real data on this. I know anecdotally, a lot of people will show that they are able to catch up a fair amount with this, but they're getting sleep deprived. So we don't know necessarily how well they're doing on the exam. There were many colleagues in med school who were doing that. I always think that I had a student years ago who brought up what would happen if after the STEP exams, after every physician, every med student in training had to do a urine screen at the end of the STEP exam. I thought that was very fascinating, like how many, and at least some of the colleagues or peers that I know, they described it as, they thought that they were cheating. It felt like they were cheating. Now these are folks who are not on maintenance Adderall. They're taking a low dose of Adderall leading up to the exam and then taking the exam. So once again, performance enhancement. Other questions? Go ahead.
I've seen them psychiatrists use the stimulants in addition to mood stabilizers or antidepressants. Is it augmenting or is it a different diagnosis?
That would be for yeah. Let me repeat that. Make sure I have it right. Is the if you had somebody who would be on, let's say, a mood stabilizer and then also prescribed a stimulant, and is the stimulant? I believe that Stimulant meds are not FDA approved or shown beneficial for like bipolar treatment. So that would be the treatment of two conditions, is you'd actually have, or let's say an antidepressant plus a stimulant medication. Stimulant meds do not seem, there's one study I read that we were very nervous that if you had somebody with bipolar disorder, if you put them on Adderall, are they at a higher likelihood of being pushed into a manic or hypomanic episode? And there is, I think, overall lower risk for that. There's not as much risk. I do have a couple patients, very rarely, who are on something like lithium and Vyvanse. And it doesn't seem to be aggravating their bipolar. There's actually more data of pure serotonin meds aggravating bipolar. That which sounds kind of strange, but that's at least what I read. Yeah, go ahead.
How would you decide which stimulant to prescribe a patient? You mentioned Vyvanse, Ritalin. I understand short acting versus long acting, but how do people choose which one to go for?
So we break them in half, and we've got the amphetamine products and the Ritalin products. And so the big one, I'll tell you, the only pills that I'm actually working with patients are Adderall XR, Adderall immediate release rarely, Vyvanse, and then Concerta. And then so Concerta is the long-acting Ritalin product or methylphenidate product. The data shows for some reason it's about a 50-50 split in terms of, let's say you had somebody with a well-established young age ADHD. Are they going to more likely respond to the methylphenidate products or the amphetamine products? And the data is about split, so it's about 50-50. So it is a trial and error with this. I will either start somebody on 18 of Concerta or maybe 10 of the extended release Adderall, or maybe a little bit based on their age. And then kind of go from there. We're doing, just as the boundaries for this, the peak of the Concerta, I'm really maxing out is at 54 milligrams, so it's 18 to 54 is the range. Adderall XR, it's really 10 to 30 is the FDA approved range. It's really complicated when I have folks come in and they're like looking pretty good, they're pretty functional patients, but they're on 30 and 30 of Adderall XR. And they're like, well, I've been taking this for 2 years and my accounting career is looking good. And I'm like, okay, that's in an upper echelon dosing. So I usually leave it alone, but I have to keep my eyes peeled about some of that. And then the Vyvanse is 30 to 70. That's the dose range. So those are the three main things we're looking at. One thing I will say that I work with a lot of families, and a very common question is parents who are dealing with the kid is struggling with attentional issues or ADHD issues, and they'll raise the idea of talk therapy. Should they refer their kid to therapy regarding ADHD? I actually discourage that, and I would struggle. And the reason is because what has markedly outperformed counseling for ADHD, at least in young adults or in kids, is a rigorous exercise program. So strong exercise outperforms counseling for distractibility and focus. So it's almost like the highest effect size is Adderall. Adderall has an effect size of like 0.9 for really ADHD. So incredibly strong impact. So even though it is a dicey tool, if you will, for the folks we have, especially if we're straddling addictive issues and things like that, it's hard to ignore the effect size of it because it does work so well. Then there's a whole world of approaches with this that I don't know much about, which is like dietary modifications and other kinds of things. But for the most part, we're starting with a low dose of an extended release, either amphetamine or Ritalin product. For folks or for parents who are like, I don't really like that, I don't want my child on meds, then I really will walk through with them, what does the real exercise program really look like? Are they playing team sports? Are they doing cross country? Are they doing things like that? Other questions? Any questions from the chat right now?
Not yet.
Okay. Okay, so we got partial diversion, which is that people are kind of passing back and forth intermittently with their significant other or somebody that they live with. There's the full transaction diversion. That's what we think of as somebody's just outright selling their bottle of pills. I I think it's really in the realm of transaction diversion, but we have a lot of people that are doing a trade. There's some sort of a prescription trade that's going on. They're getting this, but they're trading part of their Adderall for additional fentanyl pills. I think it's important to know the value of these. Usually, stimulant medications seem to also be priced in the range of about $1 a milligram. So that means that an XR10 of Adderall or an immediate release 10 is worth in the range of about $10. So a little bit similar to how oxycodone pricing was of years past. That was always about $1 per milligram conversion. So if you had somebody who was doing 100 milligrams a day of OxyContin or oxycodone, they're oftentimes spending about $100 a day for that. Simplest thing I would say is the best practices is really just on trying to increase transparency of this. So you're trying to look at, we've got the prescription drug monitoring program, and then really this topic of boundaries. And if there was one thing that I will, if it sounds fluffy, the gift I will give to every one of you is permission to up your aggression, if you will, regarding some of these topics. I take a very firm, almost mildly aggressive approach with a lot of my patients. I basically say that these medication strategies are about functional improvement. And if I really don't see it, if you have a very difficult time of telling me a story that your functioning is going up on these meds or that you're doing generally well in your recovery or in your life, I reserve the right to pull these meds away. I just take, and it's really just it's probably an exceptional boundary approach. And the reason I do that is because and I'll talk a little bit about this, but in terms of as prescribers, when we're working with patients, there's not a lot of other prescriptions and other conditions where the patients have such an urgency or such an aggression or demandingness to get their prescriptions filled. It's very emulative, and I think that should be, if you have a patient who is, they seem to be lax on filling their metoprolol scripts or their Lipitor scripts, but they're very demanding on when they can get their Adderall script. That should set off a little bit of a bell in your mind in terms of the neediness. Now, are they necessarily in a full addictive use disorder to this? Not necessarily. But I think you have to keep your eyes peeled for this as looking at a little bit of a spectrum kind of condition. Okay. So this is some of the data that we have from Cedar, and I thought that this was really fascinating. This is old. This is maybe 7 years ago, in which we were doing more rigorous testing. We did computerized testing of the folks that we had. It was called the Connors CPT2 data. And these are all the patients who said, I have ADHD. I know I'm here to address my opioid use or my alcohol use. If you could please restart my Vyvanse. They say the same thing. And then I would start by pulling up the prescription drug monitoring program. And they would say, see, I have a prescriber in the community. This prescriber is prescribing this. It's prescribed. It's on the up and up. If you could please prescribe it. We would say, well, we're not going to do anything just yet. Okay? Part is because you're in a healing path. We're trying to let your brain kind of settle down and recalibrate. We would offer them testing. The data that we showed was only 40% were actually scoring positive for this. And these are folks who had a bona fide ADHD diagnosis in their background and had a bona fide prescription for it. So I think it was very telling. I had one patient, this is many years ago, who was in a master's program. This person did the testing, was very demanding about her Adderall. We did the testing. We actually did pretty sophisticated neuropsych testing. She scored in like the half percentile for things. So like the 0.5%. And I asked her, and she's like very communicative and interacting with us and comes across as very sharp. I'm like, so you're telling me that your brain horsepower is markedly worse than our folks with severe dementia? Let's just jump right to it. You sandbagged this test. And she did. When we actually tested some of the validity scales, it scored as invalid. So interestingly enough, even if you have certain testing, patients can they want what they want. And the folks that we have are dealing with active use disorders, they want what they want when they want it. So this is where we have to kind of play defense as a treatment center around this topic. I'm sure many of the people on this call have experienced that as well, where you feel like you're in your office, you're working with a patient regarding prescriptions, especially this, but also, of course, opioid prescribing and benzodiazepine prescribing, where there's this angle of like you have to play defense. Okay. And last but not least about this, looking at the negative outcomes, what are the mild negative outcomes? This might not actually be mild, this may be more severe, which is the idea of prescriber-morale. So a feeling of having to play defense repeatedly with patients and feeling somewhat used, or that this is really just transactional about patients. And then this idea of wasted time. This is so clear an issue. They're under federal attack right now, but there's a whole run of new websites. There's one that was almost notorious website. It was called Done, and it was Get Your ADHD Meds. That was the website. So these are hyper-tailored telehealth approaches where you can't. They're not pulling any punches. This is a consumer service website. Call this number, get set up with a prescriber to get your Adderall, and that's what their approach was. Okay, this is a topic that we actually use in more specialty approaches. We call this cross addiction. It basically means that they're on the road to address, or that, Brandon, go ahead.
So there's a question that I think might be relevant to ask now. Do you routinely do follow-up visits to refill drugs like Adderall, whether telehealth or in person? What's your approach to that?
The least I'm seeing somebody is every 3 months. The prescriptions don't, and some of this is even practical, which is a good safeguard. We can, of course, as people probably know, you can't do refills on these medications. So I will have for I'll say my higher functioning patients, where they're on people that are attorneys and things, they're on XR10 of Adderall, so they're on a lower dose of Adderall. They seem to be pretty put together in terms of their family system. They're very reliable patients. In some ways, I trust them. I mean, that they're really using this for appropriate reasons. I'm seeing them on a 3-month basis. And then folks where we're probably the least I'm seeing, or the most aggressive I'm seeing people is, for these is at least monthly, to try to get a handle on it. It's also important to know that I have had patients where we start out on this initiative, it seems to work, they stay put, but maybe a year down the road, they have some sort of a problem. They have some sort of maybe a relapse, or possibly they were starting to grow an addictive disorder to the amphetamines, but just not letting me know. So I've had that, I'm guilty of that many times, of patients where we put them on Vyvanse, we thought it was going well, and then they missed a couple appointments, and then I got a call from somebody's spouse, and sometimes that spouse is yelling at me for prescribing them on Vyvanse. But now we have a real problem here. They've tripled their dose, or they've done some things at home. Okay.
In terms of the follow-up, are you doing urine drug screens? And if so, how are you using that information? I'll just share.
I'm not as much, but
not as much, because I feel like we don't. Just my observation, and this is probably true for me too, is that we're not doing that routinely in the way that we might in patients who are on, say, opioids.
Yeah, I think then you're really in the land of specialty care. If you're starting to do urine drug screens, I think some internal docs could be doing that in their office, but that's a big operation, because you also have to navigate if you have what do you do if you have contested positives? Do you have options to send it out and do confirmatory testing? So I actually use urine screen testing in my office more for motivational reasons, which is like almost like it's most useful for me if I believe the person is going to be positive and we're trying to move to becoming negative on a screen. So that would be very big with opioid use or with methamphetamine use or cannabis use. So that's a very realistic, and I'm using it really as a motivational tool. In a lot of our outpatient programming that we're doing at Cedar, so in the group therapy or the IOP initiatives, there's very rigorous urine drug screen testing that's part of it. So testing for amphetamine is going to be complicated unless you are concerned about concurrent use of methamphetamine in addition to prescribed amphetamine. So if somebody is in, you could do that if they were, let's say they're in recovery from opioids or they're in recovery from meth. But for the most part, I would give you a simple boundary. If you have anybody who has a methamphetamine history, I would block out amphetamine prescriptions. There are some docs who will argue with me on that. They say there's data for this middle of the road prescribing or trying to just because methamphetamine and Adderall are different. I just disagree. I've never seen that really pan out well. I just think that that's a clean boundary that's probably wise to take, because you get into this land that then you're in a contested position with your patient. It's difficult. So I think for the most part, you just don't even want to get into it. Go ahead.
Question about that in particular. I feel like there's literature to suggest that untreated ADHD is a risk factor for stimulant use disorder. And so for people who, I guess I've seen cases where people had a diagnosis of ADHD, they were on the meds for a while, whatever. I just had a case of this at Denver Health the other day. Fell off their parents' insurance, no longer getting their ADHD meds, start using methamphetamines at some point. Like, I guess you take a firm line, like you don't think there are any cases in which prescribing stimulants for folks like that may actually reduce their risk of using.
That's not, it's the idea you can't go back.
Yeah.
So it had to do with the real topic here, which was very sensible, is could you use Adderall a little bit analogous to methadone? Could for somebody who had a really out of control use disorder to a really ballistic substance, could you do a substitution approach with a safer version? Or maybe a little, the methadone was more parallel. I would really discourage a harm reduction idea of like, well, and at least some of the studies I've seen showed that people are just using meth in addition. So they're not actually abstaining from meth as an alternative, unlike the methadone data that when we have people really stable on a consistent dose of methadone, they're losing interest in heroin or in fentanyl. It does not seem to be that case. So I read one study that showed that ADHD symptoms do improve and people keep using meth anyways. So, go ahead.
So what is the legality of prescribing, say, extended release Adderall in someone who has a methamphetamine use disorder and a questionable ADHD diagnosis? Similarly, you can't prescribe oxycodone to treat opioid use disorder in the United States. Can you prescribe?
You definitely can. I wouldn't say it's not. It's illegal. But is it FDA approved? No. Like, I mean, you're out of. It's not within the guideline. But it's a little bit different. Like if you were prescribing, the big dilemma, the big parallel would be is prescribing methadone for opioid use disorder, but not under a methadone, not under an OTP. Whereas you can legally prescribe methadone for chronic pain, but you can't legally prescribe methadone for opioid use disorder. It's not as clear as that with Adderall, but I would say from a guideline approach, I would totally stay away from it. I take that approach. If you have, it's an interesting, we do reach a little bit of I've had patients we reach in some ways a standoff in which they're like, yes, I agree, I have amphetamine use disorder, or I understand I'm addicted to meth and alcohol and things like that, but I have ADHD, what are you gonna do about that? And they pass the ball back to me. And I really just set the ball on the ground. I said, we're not giving you amphetamines. I'm sorry. We can use blood pressure meds, we can use clonidine, we can use guanfacine, or we can use Strattera, or we can use probably the best approach, but they don't want to hear this because they like immediate. Let's get you highly involved in a rigorous exercise plan. That they're getting them into more extreme sports. And of the folks that I've seen who have really won, that's what they've done. They've done things. They've taken the other thing about this that's also very useful, but keep in mind, I'm working with these patients on the continuum of care. So they're grappling with their addiction. They're kind of in it. I pay a lot of attention to how fearful they are. But usually if patients are highly motivated to stabilize their life, they have a healthy dose of fear around these meds. They understand that they love these meds. And so they're trying to ward off their addiction versus the people who are like, yeah, I get it, I have these addictive issues, but don't mess with these meds. The same thing with Xanax. It was the exact same parallel approaches. It's just like, I understand I'm in here for my alcoholism, but don't mess with these meds. And I'm like, it's just a negative prognostic sign, really, in terms of where they're at, in terms of willingness to keep themselves safe. So the approaches we're going to use are, we're going to try to put your recovery first. We're going to emphasize safety above all costs. And I think that is one thing I would really encourage everybody on this call to really think about is if you have just these clear boundaries that it usually goes overall well if a patient has some willingness to stick with you and not just kind of fire you or leave care. And vice versa, if you say, well, maybe let's try this and let's see how it goes. That's very, what's a parallel? I'm just thinking of off the cuff. With my kids, like, well, I know you guys have some school exam tomorrow. We can watch a movie tonight, just if you promise to do well in the exam. Like, they're all gonna say yes. I have never had a patient where they're like, should I be on Adderall or not? I'm like, well, we could try it. It's dangerous, but we could try it. This is a risk-taking group of people. Everybody is saying, yeah, let's do it. Sounds like a good try. Very similar to, we could try Xanax for your anxiety, but there's risk here. You want to try it? Yes. Nobody's like, no, let's play it safe. It's just not what they're doing. So the person who's most powerful in this interaction, who is running the show, is you. You are by far the most powerful. Yeah, go ahead.
Questions are coming in on the chat now, and so I'll just go one by one if that's okay.
Sure. Yep.
How effective is bupropion in managing ADHD?
Soft.
I guess is one question, and then the other is what about in people with prior meth addiction?
I would do Wellbutrin or bupropion with a prior meth addiction. Soft data for ADHD, we thought it would do more because it's a dopamine-based antidepressant. It was very logical that it would help with concentration. It really did not. It helped with concentration with folks who were markedly depressed. But there was some study, a couple of people have cited that, I don't know the name of the study, but it was looking at Wellbutrin plus, almost like a contrave approach, was Wellbutrin plus naltrexone for methamphetamine use disorder, or amphetamine use disorder, and that showed that was a positive signal. So I would do that. Wellbutrin is a go-to med. It's one of the more commonly prescribed meds we're going to use in residential treatment, and especially for somebody who has amphetamine use disorder plus some spectrum of clinical depression, especially somebody with fatigue plus the clinical depression, or with tobacco. We were trying, like, Wellbutrin has a lot of opportunities for kill 2 or 3 birds with one stone. So we like to use it.
Thank you. When do you start to think about having people come off stimulant therapy? I guess the analogy would be people who are, have history of depression, they go on, say, SSRI, they often ask, when can I come off this? And you might say, well, aren't you doing better after a couple of years or something? So do you have an approach like that with stimulants, or is this?
So that's a good question. For the most part, no. And the reason is, if you look at this from a bird's eye view, ADHD, real ADHD is more of a state-based condition. So that argues that if the diagnosis is really valid, they maybe should need an indefinite maintenance approach on an ADHD med. Of the folks I've had who have come off stimulant meds, it's usually out of harm. They found themselves into trouble. I've had some very good patients over the years who have flagged themselves, which is very powerful. That's nothing says motivation like that. If somebody calls me up and they're like, we tried Vyvanse, but no good. I like this too much. This is going to be really dangerous for me. That's very useful, because that means that then of course we're coming off of it. But the other very common reason of coming off stimulant medication is usually the really practical is an abrupt surge in blood pressure. That people are on a maintenance blood pressure, or their blood pressure is in an average range, and they bump into a higher echelon range, and then we're going to have to pull the plug on the stimulant medication if you really think that it was really caused by that. or significant weight loss. Like
What
people are
pregnancy?
they're really not. Yes, yeah. And also at, I would. Yeah, I think that's another, but that's also, once again, I'm with most pregnancies, usually with meds, I'm leaving them alone, including even things like lithium and some of these meds that have really valid birth defect risks, but that is because of the real harm of them dropping into a severe mood episode. We're really trying, and there's a lot of data that shows that their emotional instability is so damaging to the pregnancy. But that's a little bit telling of how I think of all the stimulant medications. Once again, these are functional meds to try to maximize performance at work. If you don't have that, I'm okay with that. So hence, yes, I'm going to be pulling away Adderall or Concerta, at least for the first half of the pregnancy, probably the full. Interestingly enough, I've had a lot of patients also voice that, like they're like, I want to come off but a lot of the patients I'm working with in my office are higher functioning. When they get pregnant, they're like, I'm stopping the Adderall, I need to, and things like that.
There's another question about patients who are older, like retired professors, retired lawyers, who've been on stimulants for many, many years, and they remain on them. I did better while I was on them, and I feel like it's helping my mental sharpness. Do you say, let's try life without these, or do you say, okay?
I would leave it alone. I probably would leave it alone. I just pay strong attention to blood pressure. I try to keep the dosing low. Of those, I have numerous patients where the common dosing, probably the most common prescription I have of stimulant medications is probably the Adderall XR 10 milligrams. There's also practical reasons. It seems to be, this is more dealing with workflow. These meds are probably, I'm sure people in the chat where they're getting called because there's certain pharmacies don't have these meds. So they're like, well, can you call it into, this is a little bit of, now I'm just venting the thorn in my side of where I have I meet a patient, we have prescriptions, and then at the 1 month mark, they call me again, and they're like, if you could pivot my prescriptions around to this other pharmacy, because this pharmacy has it, and this doesn't, and I have to do that, and then I have to pivot back. So I'm doing a lot of fine tuning, really just to make sure that they get their meds based on supply. It's really supply chain stuff. But I found that the XR 10 milligrams seems to work, seems to be available.
Is there a most rigorous screening tool that you like? I know sort of looking at some of these, it seems like if you just look at the criteria, 90% of the population is going to screen positive probably.
Yeah.
But if you found one that you feel like is most useful to help identify appropriate patients?
I'm not doing a lot of that. Once again, there's the Connors data, or the CPT2. Self-reports, I'm paying a lot of attention to, and I'll talk about this maybe at one slide, the idea of, is this a prescriber-initiated approach versus a patient-requested approach? And that's very different. I have some patients where they're not doing well, and I'm like, have you thought about ADHD? And they're like, no, I haven't. That's a very different dialogue. Everything about that goes very different than, my old doctor is retiring, if I could see you and I need my Adderall. So that is just a very different overall framework with that. There was one study I read was that with some of the really simple screening, like the idea of checking the check boxes, they actually coached, it was a mini experiment, but they coached people up on this screening and to say, we're going to get you an appointment with a provider or prescriber. And I think it was 95% successfully left the office with a stimulant prescription. So it basically means that some of these real simple screening tools, just check boxes, don't seem to matter much with this. They might matter more with with children, especially parents completing it. If you really have somebody who's quite curious if they have ADHD or not, instead of somebody who is, once again, intent on getting a prescription. The folks who are intent on getting prescriptions, it doesn't screen them out in any way. Okay. let me talk a little bit about the element of trauma. So the impact of childhood trauma is markedly correlated with addictive disorders, both as a teen and later in life. Trauma contributes also to multiple other things, including the whole world of behavioral health conditions, but also a lot of physical health conditions as well. Heart disease, chronic pain. I'm not going to go too far into this, but it really is, I'm sure you guys have had talks or lectures where people have brought up the adverse childhood experiences research out of Kaiser in California in the 90s. So we call this as the ACEs data. This is a 10-item questionnaire that really scored people as in what kind of a trauma burden, if you will, was in their household growing up. And if you have, this can be a very useful thing if you're talking about, if you don't know what to do and what maybe a little bit connected to screening, I might do this screening over some sort of a stock ADHD screening in a little bit of a different way. I would do this to see really the cutoff, just so people know the cutoff is 4. If you have an individual who you do the ACEs screening, the 10-item questionnaire, and they're in 4 or up, that's a higher echelon group for all sorts of things. So if I have somebody who we do this screening and they score in this upper territory, I'm going to be instantly more cautious around controlled substance prescribing, just across the board. Okay. Once again, yeah, 10 question screening prior to age 18, 17,000 participants out of Kaiser in the mid-90s. Okay. If offering prescriptive treatment with controlled substances for chronic health, here are some general guidelines. Okay, so number 1, boundaries. I actually got this from, I allude to a little bit of like parenting ideas, but it is something like that. There's this framework that I've used that I think is really good. It's called an authoritative mindset. And so this is an authoritative from a parenting. You have on the y-axis is responsiveness, or how attuned are you to their needs. And then on the x-axis is the demandingness kind of element. So, and I think you could probably look at different colleagues. I'm sure you guys could list different physician colleagues or prescriber colleagues who are either in the neglectful, hopefully not too often in a neglectful territory, but we've definitely seen that. A lot of in a permissive territory, that tends to be more correlated with burnout. People they're frustrated, they're kind of tired. The golf course looks better than the office every day, so they take a permissive stance. They're really just, it leads to patient requests are always getting honored. The topic of, this is getting a little bit off the rails, but with Daniel Kahneman's work around the idea of noise and the idea of that for prescribers, if you see patients in the afternoon, they're higher likelihood to leave with an antibiotic prescription than if you saw them for the exact same condition prior to the noon hour. So that was, have people heard that before? I don't know any talks. I think it's really very fascinating. And it's just like so that's where what's happening is the physicians are becoming more permissive. So the idea is trying to take an authoritative stance, which is a collaborative problem solving, clear rules and expectations, and then open communication, and then also natural consequences. So a classic with this is I take a natural consequences approach if my patients, for any reason at all, for some reason have lost their prescriptions. Like if they lost them, if they can't find them, if there's some sort of an issue and they need help, and they have a whole story, I really just take a stance of you're just going to have to negotiate that with the pharmacy in terms of what time or what date it's appropriate or available for you to fill your prescription. And that seems to work with this. You might get pushback, but I think it's the only way, because otherwise you're never going to know. You're never going to, you're going to be playing catch up and second guessing everything of what's going on. And at the very least, even if they are in the land of more of like a substance use disorder, it is slowing them down. It's pumping the brakes, and which it extends things, and it allows more to kind of show up, including if they need to finally find their way into full residential treatment because things are totally out of control. I think one of the worst things you can do is be so hyper responsive that whenever they're asking for their Adderall to be refilled, you're immediately doing it every time and things like that. But it's important to know authoritative in this framework is not authoritarian. So authoritarian is a little bit too controlling. It's not really, it doesn't have good relationships with the patients. One-way communication is what that would be. Okay. I mentioned this before, patient requested versus disease focused. So is the patient reaching out for an Adderall prescription, either by an overt or covert request, or are they interested in treatment options for ADHD? Or once again, are you introducing it? Like you've struggled with active alcohol use, and this has been going on for a long time. I personally pay more attention to the hyperactive elements with this. So if I have a patient who they're like, I can't focus, I trust my mental status exam, if you will. So it's interesting. I have a lot of patients, including folks at Cedar, they're sitting down with me. I mentioned the story of the patient who sandbagged the testing. They're sitting still in their chair. They're very interactive. This is somebody who is used, they're negotiating. They're like effectively negotiating, but they have incapacitating ADHD. I basically just say, I just don't buy it. I just don't think, usually the folks who have more of a hyperactive, they're very uncomfortable in their body. They're squirming around. They're late to all the appointments. They're very scattered in how they look and how they come across. Okay? Instead of, so if I have a patient who looks composed in the body, but they cannot concentrate at all, I'll challenge them a little bit more. I'll be like, what do you really mean with this? Because in terms of this dialogue we're having, you look pretty good. Okay, I mentioned this also last week, just having some sense of levels of care. So chronic conditions, especially addictive disorders, we initiate treatment very often at an outpatient level of care, but we have an understanding of what are the higher levels. So that would be all the way up to residential treatment. I don't believe this topic of stimulant discontinuation, if anybody is really in the land of a use disorder, they really have compulsive use of Adderall or of amphetamine in any way, the idea of tapering it is a non-starter. That will not succeed. So the idea of we have to do a full stop from their substance. And if that needs to be in a residential care setting, of course we can do that. The detox in these instances is more analogous to a methamphetamine detox. Very often people will want to, one of my colleagues would always say they want to eat, sleep, and be left alone. And that's really what we see. I've only succeeded in getting patients where stimulant use was completely out of control. Where we got them into structured care was with significant family support. So where they had a spouse and said, we have to bring you into a care center. It's very difficult to get somebody who is dealing with an Adderall addiction or a complete use disorder and out of control, especially if they have functional stuff going on in their life, which is paradoxical. We have a lot of the folks that we have in residential treatment right now who have amphetamine use disorder. Very often they've totally lost housing, things are totally out of control. So they're seeking the safe environment, not just for, I want to get healthy. They will frame it that way, but there's other factors. They're in a crisis, essentially, that they have to get healthy. But some of the patients I've had the hardest go of it is where they're working a sales job, they're on 100 milligrams or 120 milligrams of Adderall a day. Things feel totally out of control and they're very pushed back about any sort of treatment. But this is what we need to do. We need to do really a full stop. And then we would do symptom. I think the biggest issue is supportive care and then symptom management for psychosis. So it's very common. One of the more common meds we're actually prescribing also at Cedar these days is olanzapine or Zyprexa. We have a lot of patients where we're giving them 5 milligrams of Zyprexa for hallucinations or paranoia that is strongly associated with methamphetamine use. Our hope is that it's really just substance-induced psychosis and is really caused by the stimulant instead of more of a major mental illness. So it's either a bipolar condition or a schizophrenia condition that they're fighting with. There is some off-label data of modafinil. This is more for meth data, so I'm not aware of really studies that looked at modafinil as a, but now we're starting to get a little bit complicated because this is a controlled substance there is some misuse potential for modafinil in terms of, but most of the data was relapse prevention from methamphetamine during it was like the first 3 months of them quitting meth. Okay, if outpatient fails, we're going to use the continuum of care, starting at a higher level and then stepping them down. So these, once again, these are the levels of care: medical, detox, residential, sober living environments, day treatment programs, IOP or intensive outpatient, and eventually landing back in outpatient care. If you have a patient who has received really specialty treatment for addiction care, is in recovery from alcohol, is in recovery from opioids, I would be just default quite cautious around stimulant prescribing, regardless of what their past has been. And that is maybe one of the most difficult things we really face, is they'll use the past to justify the future. And it basically is, I was prescribed this in high school, I needed it to get through college. This works well for me. They have a story. This works well, and we need to pivot them off of that for different reasons based on what has evolved as the years have gone on. Okay, I'm not going to get too much into this, but these are the patient placement criteria. So these are the 6 dimensions that we really look at to kind of assign somebody: detox needs, medical, psychiatric, level of motivation, their risk or their relapse potential in their environment. So I guess coming full circle, we talked a little bit about true ADHD versus stimulant use disorder, and how there's very often with patients, there's a lot of a middle ground with this. It's very difficult to navigate. Clinical boundaries, collaborative approaches, and I know we kind of touched on some of the scenarios that we'll see. But I'll open this up, because I know if we have any questions in the chat, we can kind of.
Yep, there is one. And so with the supply chain issues, we've gotten a lot of requests. I can't get my whatever XR, can you change it to IR? I can't get a 20 milligram dose, but Walgreens has a 30 milligram dose, or vice versa.
Yes.
Do you have, how flexible are you? Or do you have sort of best practice approaches to this?
I think it all depends. I mean, it sounds bad to say it all depends. I'm trying to gauge how reliable and how functional I think this person is. I'm also trying to gauge, if you go a handful of days and have to wait to get your Adderall, how much of a catastrophe is that? One of the things that I would recommend is you're trying to get ahead of this from the beginning, and in very simple terms, you're trying to keep the dosing low. Like I have times, so if I'm trying to keep the dosing around Vyvanse 30, and instead they have Vyvanse 40, I might be more okay with that. But I think doctors they're in a dilemma if they're running at high doses for all these prescriptions. The same thing, the big one is also with Adderall. I have people on Adderall XR10, but if they call and they're like, the pharmacy just has XR15s, I might say, sure, that's fine. But it gets tricky is then, does that become their new baseline? And I don't have a great answer for that. I think usually it does, but there's some sort of dose creep over time in terms of they're kind of escalating their dosing. So we got the dose escalation over time, and then we've got the length of prescription shrinking over time. So it's very analogous to looking at the world of opioid and painkiller. Like, is there a dose escalation and a compression? Yeah, go ahead.
I have some patients that say they really only need their stimulant Monday through Friday with work. That's when they need it to improve their function. Whereas there's definitely others who are taking it every single day. Is that a scenario where you think this is really just the spectrum of the disease that is ADHD, where some people it's more severe, they need it Monday through Sunday, others it's less severe, they just need it Monday through Friday? I'm wondering what your thoughts are on that.
I actually, of the patients who say, now keep in mind, this is connected to my rubric and the way I'm thinking through all these patients and working with them. Of the patients who are like, I'm going to take this Monday through Friday really attached to work, I tend to say thumbs up. I actually like that better. Some of this may involve that this is more teenage mental health and young adult mental health. Very often, true ADHD, where it does help them, their personality don't like it as much. They're like, I'm less entertaining, I'm less fun. Like my weekends, I want to relax and I want to do stuff. And I don't want my Adderall on the weekends. I tend to think that that's a little bit more on the up and up patient. They're kind of using this as a functional, I need this really connected to my work. But otherwise, I don't really want it. Like when we go to Hawaii, I'm not gonna take my Adderall in Hawaii. Versus patients who are like, I need this every single day. It also feels safer to me in the addictive land. People who are able to be like, I take this Monday through Friday and then don't, they clearly have more control over the medication. This is a tool for their functional life, instead of people where it starts to feel like they really don't have much control anymore. I just need it all the time. It also, another thing to keep in mind with that, that's another argument for trying to keep the dose reined in. Because if you're on a lower dose, if people get really high dose, they get to a point that they really have a crash. And so if you're on 30 milligrams, 40, 50, 60 of Adderall, can you not take it on Saturday, Sunday? You might sleep until noon most of those days because there's a fall off. But I don't think people are doing that if they're on 10, 15, 20 of Adderall.
One more question. We see a lot of new patients. I'm thinking about this in particular from the perspective of our residents who have a lot of availability. So they see a lot of new patients in their clinic time. And a number of patients come in and they're, on a stimulant drug, a history of ADHD. And I find that probably because of the volume of it, probably because of how common this is, I find that even from the attending perspective of it feels like there's very casual, the approach to managing this condition. And I never feel good when it's like the patient's 30, they have no medical history, they have ADHD, they're on a stimulant, they're here to get their drug refilled.
Yep.
And it's just like, I just don't like that feeling. And I don't know if I need to just get over that, and this is just how it is, or if you feel like, look, like at a minimum, you need to be thinking about these three things. You need to make sure that this has been going on since childhood, that this is like a fixed deficit, that they had this dramatic change in function on the stimulant drug, that they have no history of substance abuse disorder, that they have no obvious comorbid conditions. Are there things, these are the things that come to my mind.
Yeah.
Are there things that come to your mind? This is the floor. These three things, you got to do this. Otherwise, you're being too casual about it.
Yeah. I think that you have to, I would agree. And I think most people, and that's kind of a clean patient. And it still feels like that because it feels customer service. That's the idea of the physician burnout. The person's like, I don't care about actually our relationship. I need your pen for this script. That's why I'm here. In some ways, I think the key with this is, this is actually, I love some of this stuff because it's sophisticated negotiation tactics. It starts with the power of no. I might even say some arbitrary no's with them, a little bit to see how they respond. When I'm voicing no with patients, that's really in the realm of boundaries. I'm reestablishing a sense of emotional safety in the relationship. This is really technical, shrinky stuff, but it's like the idea of containment. This is my office. Okay, this is not just a shop. So you start with no, and I kind of outline the no's ahead of the game. You're even just to see how they respond to it. This is I can manage this med with you. I'm happy to work with you. These are the terms, and this is how it will look. And be pretty ironclad about that. And at the end of the day, do not feel frustrated if they're giving you grief of well, my old doctor did it this way. I'll say that's just fine. You don't have to be here. I kind of just say it that way, it's a little bit of a test because of that's really tapping into more the demandingness of the patients. But if I start with a no principle and be like, these are the terms and this is how this will look. And see how usually I think the stable up and up patients will say that's just fine, or that's fair. They'll say that's fair. And I think if they say if they use that phrase, that's fair, you're good. Instead of starting to litigate that. My old doctor did it this way and I want it to be this way.
So it's a no.
Yeah.
For everybody.
Well, you start with a no. You start with a no and basically say, well, I can prescribe it. This is how it looks. And if you ever, just to outline the boundaries, you're kind of shaping the boundaries. Like if you ever have any, a really big one, that's a controversial but really valid one, is the topic of cannabis. Like I also have colleagues who have basically said, you know what, I'm not gonna prescribe to enable your cannabis use. You're smoking 3 bowls a day and you need your Adderall. Part of this is like, there's a little bit BS. You need a stimulant med to keep adequate energy going amidst the heaviness of the cannabis. That's what's happening. Like you're using this to kind of slice through. So so am I enabling you to stay a very heavy cannabis user? I actually am. That's what that. So I would look at that. That's another reason of why you might do, once again, like a drug screening with this. So I think if you would be really interesting is if you have certain, like, so if you're in Lowry or if you're at AF Williams or whatever, and you have maybe starting with just clinic policies. What are just fair clinic policies? That can help also with prescriber morale too. Just basically, like, we have a clinic policy. I'll do this in my office just because I'll just be like, here's just my personal policy, and this is just the way it is. But as a clinic, you could look at more, and that would be an interesting approach. I don't know. I'd actually be even open to helping with that. If there was ever like this is like how many, you'd almost want to run the numbers. I'd be curious. Like how many patients do you think are like the patient you described? It was like minimal medical conditions, but a maintenance stimulant.
I think it's pretty common.
Hundreds of patients probably.
I think it's hard for residents,
What's that?
it's hard for residents.
Yeah.
I remember being a resident
It's
and being
super
like,
hard for me.
Yeah.
And,
Yeah.
like, it's,
Yeah, it's the subtle, it is aggression. It's the subtle aggression of the patient.
yeah,
And you're playing defense, and it is uncomfortable. Yeah.
And I know, I feel like I could flog this to death. I don't want to do that. I know we're at time. But I think that it doesn't even have to be an antagonistic patient. I'm talking about like the easiest scenario ever. I still feel like I'm looking for ways, to use a phrase, to like pump the brakes. And I think it's easier. The person who's like, I've never been on these drugs. I've never had the diagnosis, but I'm wondering because I just can't focus anymore or something. The way that I pump the brakes there is, exploring for other potential explanations, anxiety, depression, spectrum types of things. Sure, we'll try bupropion. Maybe we'll try, what's the other non-controlled one?
Prescription-Terra.
Yes,
Yeah.
Terra.
The quantity.
I'll see you back in a couple of months. Like that's a way to sort of push it out a little bit rather than reflexively going to, the sort of nuclear option. It's way harder when they're like, I'm home from college. My parents told me I needed to see a doctor, or like, my psychiatrist kicked me out, or whatever. I graduated from my pediatrician, and now I'm here. I've been on it for 10 years. I don't know how to slow. I feel like I'm obligated to slow that train, like in a way we should have 20 years ago with opioids and didn't. I feel like, can I just slow this down a little bit? While still being thoughtful and doing right by the patient.
I mean, the idea of that's where the clinic policy is very wise, because it's the idea of this is what we do instead of this is what I do.
Mm-hmm.
This is how we handle this. And in some ways, with the idea of it is what it is, that's their framework. Like, it's hard to get patients, the idea of I came to see you, but it doesn't have to be you. It could be any people in this clinic. So it does, there's a really subtle devaluing that happens.
And that's all of healthcare. I mean, that is the healthcare system that we live in.
But these are behavioral health meds, and hence everything we talk about is this topic of the patient relationship. But it is really this is just about the meds.
Yeah, for sure.
And so you're trying to navigate the devaluing. Maybe the way to help is through policy, through guidelines. This is how we approach this in the clinic. I was always impressed by, I think it was maybe Clinica or one of the programs had a really simple policy, which is you can be on benzodiazepine medications or opioid medications, but never both. So you let us know. And it was like, and they're like, well, what about my anxiety? What about my pain? The clinic's like, we don't care. You have to pick one. And I thought that was really powerful because it was policy. It decompressed the stress off the provider.
Yeah.
That they had, it emphasized safety above all. And I think you can't go wrong with that as from a Hippocratic position. I mean, it's just we're going to focus on safety first. And the patients, I don't know, you learn a lot. I think you have to, I think some of the folks who do all the specialty addiction care, I like the gamesmanship of this. just to be really honest. I like the back and forth. It's fascinating to me. Like if somebody's like trying to manipulate me and I'm like, oh, that's interesting. So tell me more about this. Like that. I mean, so you, instead of being like, I don't have time for this. Right. So if you feel, I use a lot, even just articulating a boundary, starting with like a policy, this is how it's going to work, and just see how they respond. It's a little bit similar to like Mike Tyson's famous quote of like, everybody has a plan until they get punched in the mouth. People are coming in the clinic. They're like, well, I'm going to get my, here, hang on a second. Like, I'll get right back to you. I got to talk to my Adderall doc and get my script. It's just be like, hi, I've been through this before. If you could prescribe this. And it'll just be like, well, we'll see. These are the terms, and you're on 40. I'm going to drop you. I'm going to drop you to 30. And they're like, well, why are you doing that? And I'm like, I think it's the right thing to do. I think that's a stable, I think it's this, the upper echelon guideline is 30 for this. I know that you're on 40. Well, we're going to do 30. Like I just kind of, I'll take some of those stances, and sometimes it does really rattle patients. They're welcome to fire me. I think that is the stance. I'm always emphasizing safety and pumping the brakes. And if they can't tolerate that, they're telling me something. And then I just trust in that they're kind of proving my point in a way. I think the people, once again, the question of the people that's the most up and up, they're like, these are big meds, there's big health ramifications in terms of cardiac health, weight loss, addictive risks, sleep. There's a lot of stuff with these meds. They're not to be treated lightly. Patients who respect that, and they're like, the truth is I don't really like even taking this. I'll take it just for my work day. I kind of need it. It helps me with my work, but I don't really like it all that much. Those are what you're aiming for. Those are some of the best patients, instead of the people. And like of the college student who's home, in what way is that person diverting? They're diverting in some way, either to their friends or back and forth. I mean, there's all that stuff going on. So it's interesting. I don't know. So don't be, you are empowered to push back and say no. And also, this is more, and maybe I'll leave this final thought. This is more on negotiation tactics. So you really use this principle of no deal is better than a bad deal. I think that's very true with this. It's like they're trying to cut a deal. They're trying to create a contract or an agreement with you that you will prescribe. I will see you. This is my clinic, and then you will then do this for me. And that's a deal. They're cutting a deal with you. And you guys are half of that. To just be like, do I like this deal? Does this seem like this is a fair deal or a safe deal or a medically appropriate deal or not? And you're very empowered to be like, we just don't have a deal here. I'm not telling you what you have to do. You can go to another clinic or you can do, but just the way this looks, I'm sorry, we don't have a deal.
Yeah, it's a great. We can talk.
Great job.
It'd be fun to think about like sort of what the basement, what the floor is for like a stimulant policy, because our clinic doesn't have like we have an opioid policy, but I think it's the Wild West.